Our next speaker is Dr. Romina Pesce, speaking about uterine flipping. She is a medical doctor specializing in gynecology and obstetrics, in reproductive medicine, and in gynecological endocrinology. She also holds a Master of Science degree in human reproduction and in clinical medical research, and she has postgraduate diplomas in medical genetics, systematic reviews, and meta-analyses. She is the head of reproduction and the ART unit at the Hospital Italiano de Buenos Aires and is assistant professor of gynecology in its associated university and at the University of Buenos Aires, Argentina. She's a board member of the Argentine Society of Reproductive Medicine and a member of the Cochrane Collaboration out of the UK. She's director of several postgraduate courses and fellowships and author of several different scientific studies, papers, and book chapters in both general gynecology and human reproduction. So please join me in welcoming Dr. Romina Pesce.
So I'm going to talk about something very, very different. But first, thank you very much for inviting me to participate in this very important event for our community and scientific discipline. So I'm going to talk about uterine transposition, and let's start with this question: if is uterine transposition on your list? So all you know why oncofertility is so important. So the global incidence rate of cancer is almost 1 million new cases per year. 5% of these cases affect women with their reproductive years. And the overall survival rate at 5 years is almost 85%. But by 2025, there will be close to 100 million women at risk of ovarian and uterine dysfunction because of radio and chemotherapy. So let's talk about what we know about radiotherapy damage and how sterility dictates our fertility preservation strategies. So uterine function does not appear to be affected by chemotherapy regimens regardless of their cytotoxical potential. By contrast, radiation impacts not only to the ovary but also to the uterus and hypoaxis. So direct exposure to radiation during the spinal, abdominal, and total body radiation causes potential irreversible damage to the ovaries, and including profound ovarian dysfunction, acute ovarian failure, diminished ovarian reserve, premature menopause, and delayed puberty. Unfortunately, the detrimental effects of radiation are not limited to the ovaries, and the uterus is also targeted by the radiation. So different mechanisms play a role in the development of the uterine dysfunction after exposure to radiation. Radiation causes damage, sclerosis, and obliteration in the vascular structures of the myometrial and endometrial layers of the uterus, leading to a decrease of ovarian blood flow. And they will potentially impair the invasion of the cytotrophoblast, and it results in a defective placentation. And uterine elasticity and volume decrease by radiation-induced myometrial damage, which can lead to a preterm labor and delivery. And finally, radiation-induced damage in the glandular and stromal component of the endometrium, in particular the destruction of the basal cell layers that may cause endometrial atrophy and effective implantation process as well. So radiation-induced damage in the endometrium, myometrium, and vascular structures in the uterus can significantly compromise its function and potentially lead to infertility and adverse pregnancy outcomes such as miscarriages, stillbirth, preeclampsia, fetal growth restriction, and preterm deliveries in survivors exposed to radiation therapy. So the Wallace-Foddy-Godson model predicts the age at which ovarian failure is likely to occur after the exposure to radiation by considering the age and the radiation dose. While the radiation dose required to destroy 50% of the non-growing follicles is 2 gray, that we call the lethal dose 50. The deep changes to the uterine structures, we can significantly compromise its function and pregnancy, are seen when it's received doses between 14 and 30 days. So currently there is no method that guarantee the total protection of the uterus and the ovaries. So it's interesting to note that when we think about fertility preservation strategies with the objective of protecting our own gametes, we use a preventive logic. We perform an oocyte cryopreservation, ovarian tissue cryopreservation, we use chemoprotective agents, as we saw during the chemotherapy administration. If it's necessary, we remove the ovaries from the pelvic portion, radiation field to protect them. But facing the risk of permanent damage to the uterus, we use a substitutive logic by replacing the function of the uterus. We consider uterine surrogacy, although it is not a feasible option, or uterine transplantation, which is still experimental and is marked by all the inconveniences of the transplantation in general, as a rejection, immunosuppressive therapies, and surgical complication in the living donors, as well as the need for a second intervention to remove the uterus, once the patient had had a respected number of children. So uterine and axial transposition to the upper abdomen prior to the radiation could protect these organs, and subsequent reposition of the uterus into the pelvis could allow patients to experience a normal pregnancy. So two traditional procedures, namely radical trachelectomy and ovarian transposition, let us expect that uterus transposition may be successful. In radical trachelectomy, which is indicated for patients with cervical cancer, the uterine arteries are ligated, the cervix is partially resected, and its residual portion is fixed to the vagina. So the main concern about this procedure was the preservation of the uterine vascularization, which now is provided by the ovarian vessels. Although radical trachelectomy is a more aggressive local procedure, which involves the dissection of the cervix and the paracervical tissue, as with also the lymphadenectomy, it has been shown to have almost 65% pregnancy rate post-radical trachelectomy. In ovarian transposition, the ovaries and the gonadal vessels are dissected and repositioned up in the abdomen, which is beyond the reach of the radiation field. In patients who receive radiotherapy after ovarian transposition, the rate of preserved ovarian function varied from 60% to 90%. And the most important significantly factor associated with the preservation of the ovarian function is the distance of the ovary from the radiation field. So the location of the ovary 1.5 centimeters above the iliacal crest was associated with a higher odds of ovarian function preservation. So in uterine transposition, the ovaries are positioned far away than that, so they are protected. So let's talk about the technique itself. And when we plan the uterus transposition, we have to keep in mind the steps involved in the radical trachelectomy and ovarian transposition. The surgery starts with the transection of the both round ligament and the pelvic side wall. And then we open the two lips of the broad ligament, and we medially section it up to the uterosacral ligament, which also is cut. And then the space between the bladder and the cervix, the vesico-uterine space, is dissected near to the cervico-uterine union. And we must be very careful in this part to protect the small vessels. And then a very special moment is when we identify both uterine vessels, and then we coagulate it and ligate it just along the union to the cervix, and then we cut them. Then the vagina is sectioned and sutured, and one of the most important part is the gonadal vessels are dissected from the pelvic portion to the origin throughout an extensive dissection of the infundibulous pelvic ligament, which allows the mobilization of the uterine and axial piece to the upper abdomen. So before I show you the video, I want to briefly share with you our small number of cases. This is our first case. It's a 27-year-old patient diagnosed with an early cervical cancer. It's the first histology-informed differentiated squamous carcinoma, and the clinical and imaging tumor was smaller than 2 centimeters. The patient desired to preserve fertility, so in these cases, the recommendation was a pelvic lymphadenectomy with a radical trachelectomy and then a uterovagina anastomosis. But the result of this deferred histology showed a deep infiltration of the myocervix, lymphovascular invasion, and a larger tumor size than more than 2.5 centimeters with deep invasion. So, as you know, all these factors are a high risk of factors of recurrence of the disease. So we have to complete the treatment with a pelvic external beam radiation therapy with high doses of 45 grays. The second and our third cases were very similar. These patients were 33 and 31 years old, and both presented a rectal cancer, and their tumor size were 4 and 6 centimeters respectively. In both cases, the CT scan didn't show any metastasis or distant disease. So in both cases, the recommendation was a neoadjuvant chemoradiation, that is a radiation with a chemotherapy with a protocol which includes capecitabine and oxaliplatin. And they received almost 54 full grays. Sorry, I don't know if I can go back, but it's okay. As you certainly know, this pelvic, I see here. So, as you know, the pelvis will receive a high doses of plenty radiation, and it means that there is more than an 80 risk of permanent infertility in these patients. So, facing the risk of sterility, we should think about how to optimize our fertility strategies. And in all these patients, we perform oocyte cryopreservation, ovarian tissue cryopreservation, offer Pesce and uterine transposition all in one moment. So let's break it down into 3 separate parts. The first step is when we perform our first surgery with the transposition of the uterine piece and the ovaries to the upper abdomen next to the liver. And the second step is when the patient receives the radiant treatment. And our third step is when we perform the second surgery for repositioning the uterus into the pelvis again. So after the patient was placed, obviously in translumbal position, the surgery started with the transection of the both round ligament at the pelvic sidewall. And then we opened anterior and its posterior leaf of the broad ligament and opened immediately to section it up until we find the uterocycle ligament, and we perform like a window. And here we identify both ovarian vessels and separated from the ureter. And the gonadal vessels are then dissected from the pelvic portion to the origin. We perform the same thing in the other side, of course. And the infundibulous pelvic ligament were dissected up to the intersection with the iliacal vessels with the use of ultrasonic energy. And well, yes. The paracervical vessels and the insertion of the uterocycle ligament were coagulated and sectioned. And here we perform the same thing in the other part with the vessel, the gonadal vessels, we gently track from the gonadal vessels and dissected the infundibulus in the cephalic way to the infundibulus pelvic insertion. And here's the special part when we identify both of our uterine vessels, then we coagulate, ligate it, and cut them. We perform these things in both sides. We got the other uterus vessels, and a colpotomy ring was inserted into the vagina and helped us to cut, amputated the uterus from the vagina. And you can see how the uterine piece starts mobilizing inside the pelvis. This is the cervix. And then the vaginal bolt is sutured with separate stitches. Then we take some ovarian cortex, ovarian tissue to be cryopreserved from both ovaries. And this is me very happy with these slices of ovarian tissue to be cryopreserved. And this is our first variation from the original surgery procedure. We fixed both ovaries to the back part of the uterus. That the uterus and the ovaries is as a whole piece. And we perform this variation to reduce the risk of future additions, that the addition could be a problem when we want to reposition the uterus again in the second surgery. And you can see here how the uterus is presented in the upper abdomen. We must be very careful with the iliacal vessel, with the gonadal vessels, and you can see here the liver and the falciform ligament as well. We presented this, and this is our second variation from the original surgery. We sutured the uterus into the abdominal wall, and we didn't connect the uterus to the umbilicus, so in these cases, we inhibit the menstrual period with a generate agonist overlapped with oral contraceptive to avoid the menstrual period during the time that the uterus is transposed. So we should be aware about the pedicle length and guarantee no tensions all along it, and reduce the risk of venous thrombosis and guarantee the venous drainage. So the patient finished the radiotherapy, and we performed the second surgery to reposition the uterus into the pelvis. In this case, we should perform a carefully dissection and release of all the visible adhesion that we see here, and because they can compromise the uterine vessels, the ovaries, and the reposition of the uterus itself. And the last part is when we connect the uterus to the vagina again. So who probably is the ideal candidate for this procedure? So perhaps women 40 years of age or less with a desire to preserve fertility and carry a known child, and an indication within a pelvic radiation as a part of non-gynecological pelvic cancer, or as a part of gynecologic pelvic cancer. So in all these patients, you have a consultation with a reproductive specialist and have the ovarian reserve evaluated, but it's almost important to provide this patient with comprehensive information about the available options, which includes surrogacy options and adoptions, as well as genetic counseling. So I want to share with you our very small results. So in all our patients, the ovarian reserve was checked and were evaluated before and after the treatment, and you can see that there were no any significant differences between these values, the MLH values. And in the same way, Doppler exams show plenty of vascularization in all these cases. But the most important thing to point out is in all these cases, the radiotherapy was started no later than the 20 days after the uterus was transposed. And when the radiation had finished, the uterus was repositioned in the pelvis within the first 3 weeks. So we did our calculation, and the next cell and the uterus transposed received 0.46 gray. That means that less than a half a gray. And if the ovaries and the uterus had been remained in situ, they would have received between 45 and 54 grays. So what is the follow-up after the first surgery? So after the surgery, a regular diet must be resumed as soon as possible. And one of the most important issues when we look at we must look after and warranty is the uterine vascularization, which depends on the ovarian vessels, so we must be aware of all the situations that can lead to the stretching of the gonadal vessels. And we advise conducting a Doppler ultrasound within the first 2 or 5 days after the surgery to evaluate the uterine blood flow. We recommend an extended thromboprophylaxis regimen for at least 20 days. And if there is no complication, radiation therapy can start within the first 10 days following the surgery. And you can see here the pictures of the ultrasound. I see here the abdominal wall with the uterine piece and the both ovaries attached in the back part. And here you can see the Doppler. And another image of the Doppler, and you can see that how is well vascularized both ovaries and the uterus as well. So what do we have to keep in mind during our second surgery when we want to reposition the uterus? So during the reposition of the uterus into the pelvic cavity, we must pay special attention to the problems of adhesions. Some specific adhesions require careful management to prevent injury to the vessels and ensure the uterine perfusion. So these adhesions are the more frequent cause of avoiding the uterus to reach the pelvis. So after removing all the adhesions, the uterus and the next cell can be brought to the pelvis again. And we have to aware that the bladder may be adhered to the vaginal wall, and gentle dissection is mandatory to avoid the bladder injury. And during the reposition, it's crucial to ensure that no rotation of the piece occur as a part of, as this can lead to the twisting of the gonadal vessels and venous obstructions. You may know that radiation increases the risk of dehiscence, so one must be aware of the potential risk of the dehiscence of the cervical vaginal suture. And finally, while suturing the random broad ligament to the pelvic side wall remnant, there is a risk of injuring the external iliacal vessels and ureter. So this suture should be superficial, and ureter must be seen in all the procedure. So after the transposition, or the reposition of the uterus, in general, patients are discharged on the first or second day after the surgery and prescribe an extended thromboprophylaxis. It's important to avoid vaginal intercourse for a period of 8 weeks following the surgery or until a clinical examination confirms the absence of the vaginal dehiscence. So 3 months after reimplantation, and transvaginal ultrasound should be performed to evaluate these organs, and the hormonal should be checked also. Usually, patient will have already resumed the menstrual period, so after that, the patient have a gynecologic evaluation every 6 months for the next 2 years, and after that, they can resume the gynecologic exam as a normal schedule. In parallel, the patient must keep their oncological follow-up according to the center standard on, of course, the tumor type. So we consider regular menstrual cycles after the surgery as a sign that the ovaries and the uterus functioning normally. We also consider that the patient wait for at least 2 years before trying to get pregnant. And this is our success map. We have already performed almost 30 cases around the world, and they are still counting. But the good news is that recently 2 babies have born this year, one in July and the other in August, one in Peru and the other in Brazil. So that's the delivery of 2 healthy babies show us that the transposition and reposition of the uterus and the next cell can preserve the function of the female reproductive system. But I think that the most important thing here is that 2 pregnancy was spontaneously. So no assisted reproductive techniques were used in both cases. That's very interesting because assisted reproductive techniques, they are not always an available option in some undeveloped and developing countries. So fertility is a long-term issue influenced by short-term decisions, and this is my last slide, and this is our timeline. So once we receive the patient with a diagnosis, we work in a multidisciplinary integrated group, especially with the oncological team and fertility team. Whenever it is possible, we try to perform an oocyte cryopreservation, but in these cases, we perform an inhibit the ovarian function with a agonist depot overlapped with oral contraceptive. Then we perform in one moment. We try to perform all the strategies as we can in the surgical moment. We perform ovarian tissue cryopreservation, ovarian transposition, and uterus transposition as well. Then the patient finished the radiotherapy treatment, and then we perform the second surgery with the uterus reposition. And then the follow-up after the uterine reposition consists in ensuring that the recovery of the menstrual cyclicity as a proof of ovarian and uterine functionality. And depending on the case, after the 2 years, with a correct follow-up, the patient will be able to try to get pregnant as soon as she will. So this is my closing remarks. Is uterine transposition on your list? What I think it should be. This is a new feasible and reproducible procedure which provides a global access, especially in undeveloped and developing countries. We have to advise that the limitation of the data, the small number of patients reposition reported thus far is a very strong limitation for any conclusion. We have to optimize the time available to add all the preservation strategies as we can in one moment, especially in the surgical moment. And we have to keep working in a multidisciplinary way with different teams and ensure the decision-making process with our patients. And thank you very much for listening, and a special thank you for José Sadi and Diego Deto. They are our very young, handsome, but very, very skilled oncological surgeon of our team, and they have performed this challenging procedure. So thank you very much.
Thank you so much. That was a very elegant video for us to understand it as well. I think we have time for 1 or 2 questions.
That was really fantastic, and we have a problem, of course, whenever there's a radiation to the pelvis, we might freeze the ovary, but then we're really stuck with where do we put, what do we do with it? We'd almost rather freeze eggs than ovary if you can't use the uterus. So this is a very useful operation you described. I'm still puzzled. I know it's true, but how does the uterus survive on that tiny little ovarian artery? It's like 1/3 of a millimeter in diameter. It's a very tiny artery.
He's asking the vasculature to the uterus. How does it survive with that little vessel?
I don't know, but the experience in the radical trachelectomy shows that it's a viable option. We have already performed more than 75 procedures that no uterine transplantation, but radical trachelectomy, and we had more than 25 pregnancies at term. So I think it's function.
It's fantastic, really amazing.
Yes.
Go ahead.
Thank you so much. I'm actually a pediatric gynecologist, and so I'm always thinking about the little girls. Their uterus doesn't grow after they get irradiation. To answer Dr. Silber's question, we do a lot of colorectal cases where we're pulling down a uterus and vagina, and in many of those cases, they're hanging by the IP ligament, and those uterus and vagina survive. I don't know how, but they survive. But the question I have is, how could we apply this to a pediatric population? I think it's really hard to do a laparoscopic hysterectomy on a prepubertal uterus. We don't have the cup to protect the cervix. That was my question, because I think this is something that could be very viable for some of the kids that we see with pelvic sarcomas.
Sorry, but I can help you because I really don't know what to do in pediatric situations. I think it's more difficult than in adult ones, but I'm looking for it.
Thank you so much.
That's okay.
All right.